Hello, I'm Alastair Forbes. I'm a gastroenterologist and nutritionist in the United Kingdom. And I'm going to be talking for the next few minutes about chronic intestinal failure, but specifically the chronic intestinal failure that's not associated with short bowel syndrome. It's important that we think of this as intestinal failure is a functional diagnosis, not necessarily a structural one. We have many patients now where the problem is related to either severe inflammation or even more often now a problem with motility such that the intestine doesn't function even though its anatomical length may be relatively normal. This group of patients is very different from the short bowel patient because they don't have the problem with massive fluid loss and a need for daily fluid replacement necessarily, but they equally do often have a lot of problem with abdominal pain. And that can limit their ability to eat. So that these are the patients who not only have intestinal failure, but also have a problem with eating, where eating is painful. Partly because of that, and partly because the syndrome is rare, it's very common for these patients to have been diagnosed late. They're often thought to have psychological issues, to have merely irritable bowel syndrome, sometimes for many years before the correct diagnosis is made. That has many effects and consequences because the patient already has a chronic illness and the psychological problems that go with chronic illness, but they may on top of that have become dependent on opiates because of the pain control being a problem, and that has a significant impact on our ability to manage them, at least manage them easily. And these patients can take a lot of time, reassurance and assistance from a psychological point of view, as well as the purely nutritional one. Obviously, we try to manage these patients with enteral feeding as much as possible, but it's very characteristic that enteral feeding, even using slow delivery by gastric or jejunal tube, can be a problem because the patient perceives pain and distension. So very often we end up with these patients needing parenteral feeding. As far as the prescription for the parenteral feeding is concerned, it's actually a relatively straightforward one because we don't have to be concerned with massive quantities of fluid, high quantities of electrolytes. And it's quite often the case that we can devise a prescription that allows them to have their intravenous feeding only 4 or 5 times a week. But nonetheless, the problems with the pain control, with the general debility of the patient, means that sometimes we really feel that their management is insufficient with parenteral nutrition alone. And this is now becoming an important subgroup of the collection of patients that we consider for intestinal transplantation. For all that, most of the patients with sympathetic and multidisciplinary teamwork can be handled, can be allowed to lead a reasonably normal life with adequate pain control and good nutrition from their home parenteral nutrition network. Thank you very much.